Thank you, sir. I think as others are accumulating, I thought I'll just finish off my talk, and then all of us, once we come back and listen to Dr. Sandeep answer. So we have designed it that a little like early presentation within 12 hours or multivessel disease and delayed presentation. The second aspect will be covered by Dr. Sandeep Bansal, sir. This was supposed to be given by Rishi. I am filling it up because he had to leave with some urgent work. So I put some slides together. Excuse me for that. And what I would like to briefly discuss is tell you about some of the guidelines which are very important. It's always important for us to understand how these guideline recommendations evolve also. And there is science in it. And then initially what we thought correct would be proven wrong, and exactly opposite could come out in 2021. So initially we used to think that only culprit should be done. Then they said complete has to be done. There complete also some exceptions are there now in cardiogenic shock scenario, which I will touch upon in the 2021. This actually came as chest pain guidelines, but part of it is STEMI guidelines. Then show you some case scenarios to make it interesting, and then show some places where we could save patients, and also a little more in detail on the decision making of multivessel disease in these patients when they present with acute MI. And then this 2017 guidelines is very important in the sense that it has thrown us some important new things. Always, though we were doing radial arteries before, but in acute MIs, we were initially not doing radial punctures because it was we thought that in those days it will take more time. But in this trial, it clearly showed if it has to, one thing which has made a lot of difference is radial axis, where the complications related to femoral artery, especially in the pharmaco-invasive strategy era, where the streptokinase or the lytic therapies which are given, once you did femoral, a lot of complications used to happen. Those all are gone. So that's why radial axis became the therapy of choice and class 1 indication in acute MI. So most of the centers adopted this, but any of you who have not adopted the change to radial, please do it, because that is class 1 indication, the top indication in 2017. So if a patient of acute MI comes, please do take up patient for radial axis only, unless there is some particular problem where you're not able to do it. And this era, some controversies were there in 2012 before. People were arguing that DS will reduce to complications like SAT and things like that. On the other hand, now various trials which are written here show that probably DES is preferable even in acute MI scenarios. So there's no more discussion on it. So like how there is radial, no more discussion. I think none of us should have any doubts, and we hardly practice this. No, bare metal stents are not on shelf also in some hospitals, rightly so. So DES is the treatment of choice even in that. And complete revascularization, which was thought to be red because it was creating trouble, that is class 3, now again changed to class 2A indication with some of the new data coming up. And then thrombus aspiration, yesterday one young doctor was asking, it is well, IABP is class 3, why are you using? Similarly, the thrombus aspiration also became class 3 total test. But all of us understand this decision has to be individualized. When the patient comes very late, we choose thrombus burdens. We have done everything with the balloons. It doesn't work sometimes. If you put a thrombectomy catheter and suck it, then a lot of times the thrombus comes back. And especially in the late presenters, I think Sandeep sir would cover it, will be very useful. And then bivaridine, lot of hype before as class 1, now it became class 2A. Same thing with enoxaparin. Whatever you're comfortable with, regular heparin practice is good enough. And we want to do early hospital discharge if possible. Oxygen status did not improve. And pharmacoinvasive strategy is what is picked up, which will be covered in a separate lecture by my colleague, Dr. Ramakrishnan. Additional lipid lowering therapies, we want the lipids to come down as much low as possible. That's where I think not only high-dose statins, we take help of ezetimibe, but also PCSK9 inhibitors if required, because even the lower levels of cholesterol are producing trouble in our patients. That's why we want to keep it very low. So in the patients is not an antiplatelets. Champion trial showed cangular also can be used, but nowadays we door to balloon time generally about 1 hour. So giving ticagrelor in emergencies and switching is also okay. But if you have a single center, some of the doctors are sitting would be owning your own center where switching happens in 5 minutes. There, I think cangular has a role. You can give a cangular and take up this patient's procedure. And initially, it was worried to use about ticagrelor also. Now it is found to be safe even in lytic patients. But Prasugrel generally, unless we see the coronary anatomy, we don't give it. So polypill to increase again adherence is also become important, class 2B indications. Then some of these timelines, frames, I would skip for the sake of time, but generally less than 12 hours is what is indicated. This cartoon, I think many of you are favorable, already know about this. This is what is the concept, what is came is patient delays is one which is maximum troubling. But what we need to target is the total ischemic time. The patient coming delay is the predominant problem. That's why patient education is the most important. And once the patient comes to the hospital, we have to do the job as soon as possible. Door to balloon time should be kept in less than 60 minutes if possible. In COVID times, we analyzed our data in Apollo that we wanted to work faster. We were successfully decreased the door to balloon times to 50 minutes. Especially this problem of discussion on finances was taking a lot of time. So to remove that, then we removed that discussion on finances. Most of the patients we discussed with the administration also, they would pay. That is not there. Actually, we can do the procedures faster. Nowadays, we don't do balloons in all the patients. That's why the term called, instead of door to balloon, door to wire is what is now introduced in this guidelines. Then this concepts we all know. Then one thing is previously we used to say as rescue PCI when you're giving lytic therapy and then taking of the patient if patient was symptomatic. But now we call it as pharmaco-invasive strategy where after lysis within 2 to 24 hours, we send these patients for routine PCI. That's where it is very ideally suited for an Indian scenario that it will be covered separately. This is what is wire crossing time. The reperfusion, that is what is indicated and should be practiced. All the green ones are class 1A. So I'm talking about only class 1A indication, that means patients presenting less than 12 hours. And so ongoing pain or ongoing hemodynamic disturbances, even later, you could take up these patients. But routine in asymptomatic stable patients, we need not do angiogram. But by and large, I would confess in corporate practice, all these patients get subjected to an angiogram and decide whether to do it or not. Depending upon the anatomy which the patient has. If patient has proximal LAD, left main, a very critical blocks in the proximal vessels, you might tend to do it without even studying. But ideal practice says if the distal branch vessel disease, the patient is asymptomatic and leave it. This is where the concept of infarct-related artery and the technique and what to do with the other vessels is going through sea change with a change in concepts. There's no doubt that infarct-related artery should be opened. That is anyway class 1A indication. There's no doubt in it. And stenting is a choice. For that, it is again class 1A indicated. What should be done for a non-infarct-related artery? It is going through changes in the guidelines. That's what I want you to highlight. They become a class 2A indications now. The latest guideline in 2021, I would throw light on it. Antiplatelets, I've already told you, ticagrelor or clopidogrel can be used. And then aspirin is used. Prasugrel, unless the patient is going for PCI, we tend to avoid with lytic therapy. So the unfractionated heparin is good enough in your practice. If you're following it, you can follow it. I advise you need not go to pivaridin and enoxaparin unless you have some particular contraindication. I'd touch briefly about a minute on this 2022 21 guidelines. It is not 12. So what they said is STEMI ischemic symptoms less than 12 hours. Anyway, PCI is a class 1A indication. The STEMI in cardiogenic shock or hemodynamic instability, PCI or CABG they mentioned. But I caution you not to send these patients for CABG unless your center is geared up for CABG. By the time they arrange for surgery, then the pretty amount of time is lost. Once the patient infarcts, there's no point sending for surgery. In that scenarios where you have triple vessel disease, we generally practice infarct-related artery opening. Once the patient stabilizes, then electively you can send the patient for surgery. That is general practice we follow. So guidelines say CABG within 6 hours. So if I have mechanical complications, obviously you will send this patient for surgery like VSD, MR. Then that is the only indication where I think in acute MIs, we send the patients for surgery. Then failed reperfusion or failed lymphatic therapy, again, even if the patient comes late, still you will send these patients for PCI. So that is about infarct-related artery. There's no confusion in it. But if this is the newer guidelines in the patients with revascularization of infarct artery, little late coming, all that is clear. But what is a little more confusing in asymptomatic patients, there are very small vessels involved. Now you need not send these patients to surgery or PCI if the patient is all right. This again shows the same thing what I've mentioned. Then a word about these non-infarct arteries in patients with STEMI. That's where we have some discussion. If a patient is hemodynamically stable with STEMI and multivessel disease, successful PCI and the staged PCI is what was recommended. If not in the same sitting before discharge, or trial showed within 48 days, you can still do it, but we generally do it as a practice before discharge. That is PCI of other vessels. So then in the selected patients STEMI with complex CABG could be also given a reasonable option, but provided your center is geared up for it. And then if a patient has arteries which are not very critically important, sometimes the trials also showed if it's not important, you can leave it. What is latest in 2021, which is different, I highlighted in red. Previously, we used to think in cardiogenic shock, you open up all the vessels possible because complete revascularization helps. But the latest guideline, it's set as contraindicated because it's supposed to increase renal failure rates and produce more trouble. So patient is in shock, only do the critical vessel, you need not open all the vessels. That's what is the latest guideline recommendation will show compared to what it was before. So that is the difference, and we only say culprit vessel. And there are various trials which are mentioned here, which came out with it. Aspiration thrombectomy, I've already covered, but we have to individualize according to the patient. CRISP AMI trial, somebody asked about IABP, that's why I thought I would project this also. I included slides. We were part of this large trial, CRISP AMI study. When they were not able to recruit, it came to India. We became the leading recruiters. Though IABP, it is difficult to, that was congratulated, it is difficult to produce mortality benefit, which is almost produced some advantages which did not become statistically significant, but it gives a lot of comfort to the operator in avoiding hypotensions happening during this procedure, though it didn't reduce the infarct size. That's about IABP in acute MI. I'd show you 1-2 case examples before I close. This sort of patients, 31-year-old males, unfortunately, we do see quite commonly, comes like in front of ER, he doesn't believe himself and gets into the sort of scenarios after shock given, then you have ST elevations, and then ABP was inserted immediately. This sort of thing, why I wanted to project this is still we'd use IABP in such scenarios where patient is in shock, no blood pressure recorded immediately, it gives us some time to get some pressure back. And once IABP put, the teamwork also helps. My colleague puts an IABP, the other person starts off with doing this thing. And then you see this, LAD has a total occlusion, so critical thrombotic occlusions with slow flow there. As you know, we repeatedly do thrombectomy. This is another why I wanted to project this. Yesterday questions was about thrombectomy, why are you using? See this sort of scenarios when you have chunks of calcium there, see that chunks of thrombus, you have to suck them out. And then once we did thrombectomy, and you repeated it, and then sometimes you may not need a stent. This artery become totally all right. And we left it after this thrombectomy. And then once the flow comes back, as I said, pressures improve and the patients dramatically improve. So that sort of thing, but you need some critical care support in the post-op, immediate pulmonary edemas. And later on, ECGs improve dramatically. All these things were done before patient paid anything. So that's how once the patients improve, we feel happy about it. Day 3, patient became all right, came for follow-up, lost weight, and that's also thing is very important. One example of multivessel disease presenting stable hemodynamics, probably SC elevation about to come, then you do infarct-related artery, the tight LAD disease, then and the RC also has a critical disease and LCX was borderline disease. And then immediate stenting was done. That is, if possible, direct stenting. Then patients improved then. Then staged FFR to OM, whether to do it or not, we were having a doubt. So we did FFR pre-discharge, it came negative, and the left that thing, but RCA was looking so critical, we tackled that. And then we had to take all precautions to do a good job, post-dilatations to give good results, and then patient, now that's the final result, and the patient was discharged. Sometimes patients come in emergency scenarios like cardiogenic shock situations, especially post-bypass, and the graft get occluded in one of these patients. That's where we go out of the way to break the rules and do what is good for the patient. Then graft occlusions are producing trouble. So then we didn't have time to put filters and all that. So this is a native vessel. For sake of time, I'm skipping. So one of these graft vessels which had a tight stenosis, we opened up, and then probably Lima was all right, as seen that this is our graft, venous graft coming into the RC had a tight stenosis. Then there is a tight narrowing. I don't know whether light you can appreciate. Then this is another graft which has a very tight occlusion. So when this sort of things coming, we might open up both, which are relatively straightforward. We did direct stenting of this graft. And also for the other graft, this is again, you have to individualize, see how the patient behaves, how the procedure is going, and take decisions. I wanted to stimulate some of your thought process, why you did two together. All that is again, but you need to be taking care of it, and patients you arrested. Initially, TPA support, IABP, all that will help in taking this. We did write a consensus document in STEMI, doing that in CSI was part of it, and then very much thankful for all the support across the colleagues. I think time is up, it shows. That's how it's important to summarize, analyze these patients, and do what is best in the patient's interest. Thank you.